to talk on ultimate mimicker. Yeah.
Thank you. Thank you, sir. Thank you, AIS, for this opportunity. My topic of discussion is the ultimate mimicker. No financial interest. So, let the case begin with a patient who came to my OPD, 50-year-old female, presented with resistant unilateral conjunctivitis of the right eye. She had been treated elsewhere for 2 months with no relief. She was treated with topical antibiotics and corticosteroid for 1 month, but symptoms progressed. Detailed history reveals similar episodes over the past 3 years. So this is the eye. On examination, right eye and left eye, the right eye vision was 6/6 and left eye normal, and the lid and adnexa were normal. Conjunctiva, there was diffuse congestion, mild chemosis, no nodules or masses, lesions in the right eye, and the left eye was normal. Cornea, anterior chamber, iris and pupil were normal. And the fundus examination was also normal. The IOP was also normal. Ocular movements full in all directions, and there were no palpable lymph nodes. So conjunctival culture was done and no pathogen was identified. So, what should I do right now? I investigated, and the ESR came as 75 millimeters of mercury, HR, and Manto came as 20 millimeters, and HIV was negative. So further course, a physician consultation was sought in view of these findings. The chest X-ray and HRCT showed hilar lymphadenopathy. So a quantiferon TB gold test was done. It was turned to be positive, and she was not willing for any surgical procedure. Hence, conjunctival biopsy was not done. So in conjugation with the physician, and she was diagnosed with ocular TB, and ATT was started, and her symptoms started to improve in 2 weeks. The treatment was continued for 6 months. There was no recurrence now. It was a teamwork. Conjunctivitis is the most common cases we encountered in the OPD. Some cases may be resistant to routine treatment and needs further investigation to rule out underlying causes like tuberculosis or mass lesions. Although primary tubercular conjunctivitis is now a very rare entity, and it should be considered a differential diagnosis for unilateral chronic conjunctivitis not responding to treatment. Ocular TB is a clinical disease caused by Mycobacterium tuberculosis. The TB was various modes of transmission and can infect virtually any ocular tissues. Much like syphilis, ability to mimic multiple skin lesions, ocular TB should be thought of a great imitator of ocular pathologies. Globally, more than 1.7 billion are affected. Recognition of ocular TB as a clinical manifestation of extrapulmonary TB is critical, as a timely diagnosis can lead to early initiation of antitubercular therapy and prevent poor patient outcomes. Most cases of ocular TB are presumptive, getting histological or microbiological evidence of infection is extremely difficult. Also, the ocular disease may be due to direct infection or any immune reaction to the MTB. Uniform diagnostic criteria are lacking, and the interpretation of diagnostic modalities may vary globally. However, early detection and prompt management of cases with presumed ocular TB may lead to good outcomes. The patient may present with ocular redness, discomfort, mucopollen discharge with regional lymphadenopathy usually. Other conjunctival manifestations include subconjunctival nodules, flicton, ulcers, tuberculomas, or polyps. Tests for interferon gamma release assay and quantiferon TB are more specific, but false positive cases can occur in low endemic areas. A FNAC or a tissue biopsy attempt may be made, as the culture of MTB is the gold standard diagnosis. Demonstration of acid-fast bacilli also confirms the diagnosis of TB. However, the samples are difficult to collect, impose significant risk on patients, and the culture results may take up to 10 weeks. So in conclusion, chronic conjunctivitis should be evaluated thoroughly to rule out underlying systemic causes, especially TB in India. These are my references. Thank you.
Really, again, I was in that hall and telling that something like this is their eye-opener again, that tuberculosis is there in this country still and in world over again recurring. And like my wife was in gynae, and any infertility not responding to anything, she will give anti-tubercular treatment. And they would respond. So this is true of these things also. That even if you don't make a 100% diagnosis, a therapy of anti-tubercular treatment for maybe few weeks would start making the difference. So it's a good presentation, and I think again good education for students.
Yeah. I think rightly said, we should be aware that tuberculosis is still rampant in our country, And the commonest presentation is because of hypersensitivity in the form of lectin. But we were taught in our undergraduate, the only two causes of tuberculous conjunctival ulcer. One is TB, other is foreign body. So if there is a conjunctival ulcer, you have to rule out tuberculosis. And of course, the other forms are nodular, polyform, which are very uncommon. I have never seen. But another thing you said, culture is difficult. These days, they don't rely on TB. People don't rely on culture. They do a test called Gene Expert. So these are some things, but I think it's a...
That gold, even that gold
Quantafron.
test is not, I think gold
No.
quantafron also is no longer...
It is done for
considered-
extrapulmonary tuberculosis, they depend on, because MON2 is not available now. Unfortunately, MON2 test is not available because tuberculin...
कुछ लैब कर देती है
बिहार में है अभी
बिहार में
प्राइवेट लैब
मुश्किल से हो रहा है।
कर देते हैं मतलब मैं अपने हॉस्पिटल में भेजता हूँ तो प्राइवेट लैब्स वाले कर देते हैं
Okay.
Actually, we rely on presumptive diagnosis as well as IGRA as well as mostly, and sometimes we get a very good clue of lymphocytosis. लेकिन यही है कि this is regarding extrapulmonary tuberculosis. It's a big headache for us to I think throughout the country to force the pulmonary medicine people to start the ATT.
They are
I
They
had
are
that
very reluctant to do this. I think it's a universal phenomenon.
don't start.
But now I have succeeded somehow. I actually write why we are very, very sure why it is this tuberculosis and tuberculosis and nothing else. So
Yeah.
we are able to
Yes,
cope
madam.
with that.
I had that difficulty too. I had to call and phone him, like we will start.
Nobody,
sir.
none of your pulmonary friends will help you in this regard. कि भैया ATT शुरू कर दो, इसका vasculitis हो रहा है, इसका uveitis हो रहा है, इसका chronic conjunctivitis हो रहा है. You have to really convince them. ठीक है.
They're not doing much of it.
That was a very nice presentation.